it's not the end of it. And the open question, the open question is, what is the connection between the economic dividend and the health dividend outcome of the health economy? And now my last 10 minutes, perspective 3 as an answer, and there is a question mark. What we are measuring is macro, meso, micro performance. This is for sure. And then in all the textbook you find words like structure, process, outcome, sometimes systems of the health sector, not the health economy, and this makes the difference, on the basis of the given economic dividend input of resources. And here we cannot compare really much because, as I said, this calculation is new. The Institut für Höhere Studien in Wien, in Austria, they do now the same thing that we have done, and in Switzerland as well. When we have these figures, then we can compare at least 3 industrial states in regard to these economic variables, and this would help. But as long as we do not have these figures, we have to use other variables, and we are talking then about the health system. And here I have some easy answers. What is the healthcare sector? And this is something I'm asking all of you. Tell me, what is the healthcare sector? And don't tell me it's a health economy because I've spoken about it. Tell me what you think it is. Is it the health system? Is it the healthcare system? Is it the health market? Is it the healthcare industry? Is it the public health system? Are these the financing agents? Is it a beverage system, a Bismarckian system? And I tell you what I tell my students, I don't know anymore. It's a bundle of health indicators collected with the National Statistical Office, the Eurostat, the OECD, the World Health Organization, the World Bank, and then we are talking about figures, 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 and you need them. And here is then the international comparison. I start with the cons, and here I would say that this ranking is always arbitrary because it depends on the persons, on the commissions who sit at the table, and then they are saying, well, this is the indicator, this is the indicator, because I know then I'm first or second. And a good friend of mine, Reinhard Busse, who is sitting next to me in the university, he says, tell me first what result you would like to have, and I give you the indicators for the ranking. And this is something that is not so nice. But on the other hand, what I'm saying, the open method of coordination, as this is called by the European Commission, is delivering best practice at low cost and may hopefully come out of international comparison. Learning by comparing is the message, and I stand behind this pro and this international comparisons. What is meant by value on these different levels, and we have to talk about it, and I think you will agree with all these things that I've written down here on the different levels. You have here the microeconomic value should be measured for defined groups with similar needs. So you go into one disease and look at one region for a group of persons, for the elderly, for young people, what is going wrong and how can we help this part of the population. And then Michael Porter says the only way to accurately measure value is to track patients' outcome and cost in the long run. This is nothing new. The value measured on a mesoeconomic level and in selected markets, here I would say, well, you could do it perhaps measuring the quality of nursing homes for the elderly in different regions. This is what we have done at home, and there are so many differences, you won't believe it. And others say, well, you can do this for the pharmaceutical market as well, so you now look for sectors and look where's best practice. This is much easier than for the whole system. And this is what I'm saying here. And then I'm adding, with the background of the health economy, the social and macroeconomic benefit of better health for the society is something very important, I guess. And I don't know whether you have heard about this saying of a commissioner in the European Commission who is in charge of health affairs. He said, our objective for Europe, and this is part of you as well, next year, already now, and now listen, they said by the year of 2020, we want all 550 million Europeans with 2 additional healthy life years. So this is their objective, health, health, health. And now I'm asking the politicians, can we do so, and is it something politicians should say, because after a couple of years, you can judge then whether they were successful or not, which is not so easy to follow. I come almost to an end, and I have here a couple of points that are of importance, and I will speak a little slowlier because I think they are all important, not only for students, but for all of us. And this would be a basis for the future, because here I would show you, I guess, 9 proposals with which you can improve the value of the money for health, and where you can measure performance perhaps in a better way, but I don't have the figures. What is important, I guess, and this is true everywhere, there are inefficiency in all systems at all times. And there are always possibilities to improve value for money from a health economics perspective. This is always true. After the next reform, same thing. After the next reform, same thing. And we have had many reforms in Germany, and we are always saying after the reform is before the reform, and so it goes all the way over 30 years now. And now many more value on many different levels. And I guess you will understand them all because they are easily written here. It says here, better coordination and better navigation of patients. This is a job should be done by the funds. By avoiding overuse and inappropriate use of resources and through better financial incentives. This is a topic we are suffering from. In Germany we do a lot of good work, high quality and good results, but they are all not necessary, because the indication was in the sense that the second opinion would say, well, this is not necessary, but it was good work. And it increased the value added. So this is a problem that we are facing. The third one is through what it says here, disease management programs and centers of competence. When you hear center of competence, you can either think of research centers as the Americans have in Maryland with all the big diseases, they have a special research center, or you could think of center of certain diseases, so that you have a better treatment centers. And this is something the future, I guess, in our country, that patients go to places where the procedures are done very, very often and not just a few times. When you go further down, we have talked about this promotion of independent lifestyles. Then you see more value on many different levels by selective contracting, which means that you, as a representative of a fund, says to a hospital, well, as long as your indicators are so poor, I'm not going to make a contract with you. And then you go to office-based physician and say, well, as long as you are not really educated and you are not going to these and these courses, I won't make a contract with you. But this is easy said. Nobody's doing it in Germany so far. But we all, the economists are talking about it and like it. So this might be something for the future. And involving patients more in their own care, I guess this is done by the internet, and this is important and comes automatically. And then you need a climate for entrepreneurial and innovative behavior. And then what we need, and I'm looking to your Minister of Health, what we need is evidence-based health policy. In case we would have it, you wouldn't have to act so often, because we have had many reforms which wouldn't have been necessary in case we would have known more beforehand. But it's, again, easier said than done. We have problems already with empirical-based medicine, and now we have problems with empirical-based policy. But it would be nice, because it makes a lot of work for research, and then the people would ask us, could you find out whether this kind of policy approach is correct or is not correct? So it helps the universities to do more work, and it helps the politicians not to act too often and to intervene too often. And then what we need, this is a more framework thing, a legal framework and binding guidelines. This is something that we do not have. I cannot tell you the framework of our healthcare system is very complicated and very different items, so I could not say what is a typical framework for a part of our social market economy, which is called healthcare or healthcare system. Last but not least, it's not technology assessment that is so important, it is health assessment which is so important, and this is a major challenge from my point of view. And my last but one chart will show you what I have in mind, and this is again easy shown and seen but difficult to transfer. It would be nice if we would have here an expansion of morbidity or a comprehension or a dynamic balance. And I'm favoring, as all of you will do, the period of good health should be larger than the increased life expectancy. And this is a definition of compression of morbidity, but nobody can really prove this. that we have done this already. I guess it depends on many factors, but in case we would have this as an answer to our demographic challenges, the system at least would not be more expensive immediately, because when you die in a very old age, 92, 98, it's much cheaper than when one of us now would die or would go into the hospital and would be treated. And in case this is true, at least in healthcare, then it would be cheaper, and this would be then a compression of morbidity. But this is a lot of new research that is to be done, and I'm only favoring, of course, as all of you probably, that this additional period of good health should be larger than the increased life expectancy. I'm coming now to my final and my result, and here I would like to say that the summary for improving value for money is the perspective number one: there is no optimal health expenditure quota and no optimal structure for health expenditures. I guess it's impossible to prove that 8% or 10% together with life expectancy is something we really need. I would at least say go away from health expenditure and go to value added, go to export, and go to the number from the labor market. So then you have economic variables that are much more sensible than the expenditure side. So I'm not in favor of cost containment, cost containment, cost containment. There's no other sector where we are talking about cost containment, only in healthcare. I don't know why. And with these new variables, you have a new approach and a new understanding. The economic benefit of the health economy, I was just talking about, it should be measured regularly on the basis of the national accounting system. And I tell you what, the Central Statistical Office in Germany is trying to do this, and we have a new research project where we have the task until the end of this year, I guess, to develop a handbook that gives you all the details about these figures and what we have calculated for the regions, for the federal state, for companies, and this is then the basis for the discussion in industrial policy, and I guess this is important. And the other research project that is running is under the heading of the productivity of the health economy and the efficiency of the health economy, a topic on which we will work tomorrow, which is very important. And then I said before, additional healthy life years as a major objective. This is something that we should have in mind. And let me finish by saying what you have read already. There is no gold standard and there is no panacea for balancing all the competing demands for resources, quality and access. There is no gold standard and you won't have it. So all the 28 countries of European Union, there's no gold standard. I guess we have to work step by step and slowly, and this is my message for you. Thank you very much.